So for me, there were a couple of things that have changed, but I'm going to touch on the other thing, talking about laminoplasty, and it's not really the last year. I'll talk about that a little later. But the thing that's changed for me that really was an insight that I would have disdained earlier and criticized, because I'm a little bit of a dinosaur, but I think it's made a big difference in certain cases, not without potential risks, and these are my disclosures, is single position lateral fusion. And I thank Chevy, I thank Shiraz as well, who's taught me a little bit about this, but Chevy has really done these cases with me and shown me the way, because for some reason Globus refuses to teach me how to do it. So I've done more cases than most people, but my mentor has been Chevy, because I'm not allowed to use it without my training. But I just wanted to show a couple cases that I think have made where it's made a significant difference compared to how I would have previously done this. So here was a lady who came from Florida. She had a horrific L4 radiculopathy, failed everything. And this lady, you'll see the long films in the post-op, but she would have gotten, in my hands, a much bigger procedure than she would have gotten with this. So she had a horrible L4 radiculopathy. We passed it around the service. People said, you probably could, if you really are convinced that she only has her exiting root at 4 or 5 there, do just that level, and maybe she'll need something later, maybe not. But so we did this patient with a single position, lateral, robotic. And one thing I've noticed with this technique, bigger screws, longer screws, and more comfort in placing the instrumentation. You can't, if you're going to use a robot, don't just rely on the robot that it's going to be correct, because there's been stories where people relied on the robot and drilled and put a screw right through the canal. So do make sure you need to be a decent open surgeon and know where the landmarks are and all, and it has to make sense. But here's what this lady looked like. She's done great, left the hospital in a day or two, and is doing great at about 6 months post-op. Another great indication is a patient who's had 2 laminectomies, not 1. This guy could not literally, we assumed he had a pars fracture, didn't know, but he couldn't walk 50 yards, and all he wanted to do was play golf. He was an executive who wanted to golf. He literally got to a point he could not walk, horrific back pain every time he got up. In this case, I would have done open, dug through all the nerve roots, had a dural tear or 2 or 3, and we did him with a single position lateral. Screws, I think it took about 2.5 hours to do the case, and he did great. He had a little problem with for some reason, his belly for a day or 2. He got an ileus, but he is done. I just saw him. He's less than a month out, or maybe a month out, and he's really asking when he can get back on the golf course. So he's had a spectacular result, and he did, in fact, have a pars fracture. And when we stabilized it, he has no problem at all as pre-op pain. And just to show that things can sometimes not go as perfectly as possible, this is one of the first cases we did with trying to do, this may not have been a robotic case, but I can't remember actually. Chevy will correct me if I'm wrong. But this was a post-laminectomy guy that had such severe back pain, and you can see a degeneration throughout his lumbar spine, stenosis, and we wanted to try and do him less invasively. He had problems trying to wean from narcotics, but here's what we did. Top to bottom, we did an anterior L5S1 in the lateral position and all this instrumentation. But he ended up with a very weak kind of a femoral nerve problem that was really prolonged, and his recovery took about 8 months. He's now finally doing better, but he had to live in the basement because he couldn't even get up stairs. And I just show this case to say he'll probably ultimately do well, but doing these cases is not without, you have to be wary that they may not always do well. But I will say, thank you, Chevy, for turning me on to this, and for those who've developed it, because I think it is a good innovation in spine surgery. So thank you.
Thanks, Todd. Yeah, I mean, that was a robotic case that we did in one position. But yeah, I agree. I mean, I think there's definitely a learning curve a little bit to these cases. And just like every other new technique, it's indications and sort of figuring out the right patient to use this technique on.
Hey, can I ask a quick question to you guys? Since
Yeah.
I know that you guys probably have everything. We only have the Mazor. I'd love to know, do you guys have both the Mazor and the Globus robot?
We do, yeah. We have both.
So which one, Chevy, you seem like the robotic guy. Which one do you think is better, prefer, you know?
So I've only used, I mean, I've used a Mazor for a case or two. I have not tried it for single position. And for us, I think most of the volume that me and I don't want to speak for Shiraz, but I think the two of us are using pretty much Globus for most of it. And I think for ease of use for the single position cases, based on my limited experience with the Mazor, I think the Globus would probably win out.
Yeah, I think, Bay, the big difference is, the Mazor continues to be a bed-mounted robot, and that presents some challenges, whereas the Globus is not. So,
okay.
And then there's a little bit more ease of marrying navigation with the robot with Globus. I will say, probably, and again, I don't have experience with the newest Globus that the newest Mazor that we have. I've worked on the previous Mazor, but I will say our fellows who get a really good experience with Roger Widman with the Mazor, and he does a lot of his pediatric scolies with it, and then with Chevy and I with Globus, they tend to gravitate towards the Globus because they find it a little bit easier to use.
Okay.
But I think that they both have they're both pretty great.